Good evening. This is Walter Park. I'm the immediate past president of the Collaborative Alliance for Pancreatic Education and Research. And I'd like to welcome you all to our third of 5 sessions, weekly sessions of the 2020 Pancreas Academy. Thank you again for spending your evening with us. We kicked off this 5-week weekly webinar 2 weeks ago with a discussion of pancreatic anatomy as well as acute pancreatitis by Drs. Artur Singhi and Drs. Greg Cote. Last week we had a lecture by Dr. Chris Forsmark on chronic pancreatitis and Dr. Mark Lowe about pediatric pancreatitis. And today I think we're going to shift gears and focus on pancreatic cancer. We encourage you to ask questions, even though this is a virtual format, and we've been successful in doing this through the chat function. So strongly encourage you to use your chat function to post questions. We'll take questions and have a discussion at the end of the session. I, as the moderator, will review the chat questions and bring them to our speakers. I want to remind you that next week we will have Drs. Temels Turks, who will speak on imaging modalities of pancreatic disorders, as well as Dr. Shonak Majumdar, who will talk about pancreas cysts. And we'll conclude on August 20th with a discussion of acute pancreatitis by Anna Phillips and surgical therapy in pancreatic disorders by Catherine Morgan. This evening, we have 2 faculty who will be focusing and have expertise in pancreas cancer. Our first speaker will be Dr. Nathan Bahary from the University of Pittsburgh. He's an associate professor and medical oncologist, and he'll talk about pancreas cancer diagnosis and current treatment approaches. And followed by Dr. Amy Lucas, also an associate professor at the Icahn School of Medicine at Mount Sinai, who will be talking about pancreas cancer screening of high-risk individuals. At this point, I will stop. I will turn this over to Dr. Bahary to share his slides. Thank you.
So I'd like to thank the organizers for giving the chance to talk about pancreas cancer. I'll use the next 18 to 20 minutes to talk about the diagnosis and current treatment approaches to pancreas cancer. First thing, is it really important? We all think it is, but statistics are always nice. And we estimate that about 57,600 adults, about evenly matched between men and women, will be diagnosed. So it only causes about 3% of all cancers, but it's one of the highest causes of death from cancer. And as we can see, that 47,000 people will die. So nearly 80% of the people will die in the next year who are diagnosed with pancreas cancer. However, I don't want to make this all dismal. The 5-year survival rate for all cancers has risen from 5 to 9% over the past 10 years. I think it is going to even go higher, as we'll discuss in some aspects of diagnostic and treatment. And I like to remind people that 4% of 60,000 people is 2,400 people who are alive today that weren't a number of years ago, and are very excited to do so. So pancreatic ductal adenocarcinoma, just to make certain that we're all on the same page, here's a little cartoon of the pancreas, and looking closely at it, there's endocrine cells that secrete hormones into the blood vessels, and the exocrine cells that secrete pancreatic enzymes into the duct. And it's this area, this unit, which actually goes on to cause these cancers. So what are the risk factors, since we're talking about diagnosis of them? Diabetes is a risk factor. Interestingly enough, though, most people who get diagnosed with diabetes, the new onset, do not have pancreas cancer. Most of the people who've got pancreas cancer have some aspect of diabetes. Chronic pancreatitis, IPMNs, as Dr. Singhi in their very first talk discussed, hereditary pancreatic cancer syndromes. Family history is a very important risk factor. Jimmy Carter, former president of the United States from 1976 to 1980, had 3 siblings who got pancreas cancer. And what's interesting is when he got his cancer, it turned out to be melanoma and not pancreas. And the patients with these are now intensely followed by our GI division, and Dr. Lucas will talk much more about that in detail, of how she and her colleagues follow these people and try to identify them early. How about hereditary genetics? This is BRCA1 and 2. PALB2 are the most common, just because BRCA2 is the most common hereditary cause based on its prevalence, especially amongst the Ashkenazic Jewish population. HNPCC or Lynch syndrome, FAP, familial atypical multiple mole melanomas is a P16 mutation with an increased risk of pancreatic cancer, and the estimated lifetime risk is about 20% by age 75. Hereditary pancreatitis, Peutz-Jeghers syndrome, I've seen exactly one in my entire life, and ATM mutations are now recognized as well. So what's the presentation? Usually you present to your primary care doctor, to your GI doctor like Dr. Lucas. Everybody comes pretty much diagnosed to me with weight loss, anorexia, that is the inability to eat, loss of appetite, pain, jaundice, diabetes. And the jaundice comes from patients who have pancreatic head masses which obstruct the biliary system. Venous thromboembolism is noticed. Many people who will have a DVT, that is a clot in their lower extremities usually, that then turn out in the workup to have pancreas cancer and lab abnormalities. So if they're metastatic and they're metastatic to the liver, we'll often see liver function test abnormalities. So these patients who come in should usually get a triphasic pancreatic mass protocol. Sometimes the first CT they get is without contrast, and you go, oops, and you should get a pancreatic mass protocol with IV contrast. Triphasic means that you're getting non-contrast, venous, and arterial phases, so we can look at the blood vessels which are close to the pancreas to decide if these are removable or not. And endoscopic ultrasound and biopsy, because we need to know whether this is a neuroendocrine, an adenocarcinoma, and there's other variants which we won't really talk about because we're focusing most on the adenocarcinomas. If they're obstructed or if they've got jaundice, they need some sort of decompression, an ERCP, or an external biliary stent in order to get their the bile duct clear and their bilirubin down so that we can effectively give them chemotherapy. There's a pathology evaluation. Everybody should look at germline hereditary, especially if they're early onset, or somatic targeted sequencing, as we'll talk, because they account for the majority of cancers. CA19-9, people often ask us about using that as a screening technique. And actually, it's a very poor screening technique because it's not, the incidence is not high enough, and the sensitivity and specificity not good enough, that the predictive value positive is extremely low. So let's move to the hereditary genetics. This is something that happens embryologically. So there's a mutation in the fertilized egg or shortly thereafter, or hereditarily from the egg or the sperm from dad or mom, respectively. And as we said before, BRCA1, 2, or PALB2 are the most common. This leads to prostate, pancreatic, breast, and ovarian primarily at a younger age. So these are women who have breast cancer, ovarian cancer in their 30s, 40s, sometimes even earlier. Male breast cancer is almost exclusively BRCA2 linked. And they're directed treatments. What's important to find this is they're directed treatments in the form of chemotherapy agents that can cross-link the DNA, meaning take the two strands, bind them together, and that's linked to the fundamental role in response to cellular damage. That is, these genes are involved in specific DNA repair processes. And if you make it that they already have a problem fixing DNA and you mess up the DNA more, these work pretty well. And then there are PARP inhibitors, which we'll talk a little bit about, that are a directed treatment just at this. Hereditary non-polyposis colon cancer, HNPCC, or Lynch, accounts for a small but growing diagnosed number of patients with pancreatic cancer. There's 4 genes, as noted on the slide, that cause this, and it's linked to a fundamental role in mismatched repair. These have intestinal. I'm going to give a plug that not only do they have colon cancers, but women have an endometrial cancer risk who have this in the germline greater than their intestinal colon cancer risk. But there's also bile ducts, so we see biliary cancers, pancreas cancers. Sometimes it's difficult to tell those two apart, and we end up resecting or treating them and then finding out what we're dealing with. And what's interesting is the underlying biology of these make these tumors exquisitely sensitive to checkpoint inhibitors. So what are these like? If you bother to take a family history, one of the hardest parts we have in looking at this is if you look through most charts, people say family history non-contributory, which basically means they never really asked. And well, if you take a look at these pedigrees, you know, circles are females, affected people have a black. If they died, there's a slash through them. So here's a male who died of prostate cancer, female who had breast cancer at 45, pancreas cancer at 55, ovarian, breast, and this is the index patient with the little arrow that we're talking about. And Lynch syndrome, you'd see colon, endometrial, and perhaps pancreatic or biliary in them. But most treatments for pancreatic cancer and most of the genetics for pancreatic cancer are somatic. That is, they're not hereditary. They're actually only in the cells that are in the periphery of your body. So in the pancreas cells, in the lung cells if it's lung cancer, in the liver if you've got HCC, hepatocellular carcinomas. And so there's a number of mutational processes, right? Environmental factors or innate replication errors, toxins to the DNA repair deficiencies, editing problems can lead to all sorts of things. Gain of function mutations, loss of mutations, you lose one of them and the other one has a decreased activity, complete loss of the patient's DNA, the gene, inversions, translocations. So there's a number of these things. And if you take a look at what we know from a research perspective, if you take mice with a normal duct and you create a KRAS mutation, now KRAS mutations are in about 92% of pancreas cancers. They actually don't get pancreas cancer. They go on to get pannins that are precursors, but they require a later event, loss of a tumor suppressor such as SMAD4, P53, in order to go on to an invasive cancer. And we see this in patients as well. So you can get the same type of hereditary issues. We saw loss of BRCA1, 2, or mismatched repairs. But what happens in these cases is that both alleles, the one from mom and from dad, have been somatically lost or transformed. So it's not hereditary. It's only in the tissue of origin, in our case, the pancreas. So why we make a big deal of this when we're trying to target therapies? I'll give you an example with BRCA2. We talked about PARP inhibitors, and PARP is a type of targeted therapy that inhibits the PARP protein in cancer cells, and it's responsible for repairing damaged DNA. And so what happens is in our normal cells, if there's endogenous DNA damage, there's multiple pathways to repair this. But if the BRCA pathway, which includes a lot of other proteins in a big complex, is stopped because of a mutation, then we rely heavily upon the PARP pathway. And if we use something like laparib, which is a PARP inhibitor, and there's a whole lot of them being tested, then you actually can cause death of the cells only in those that have the BRCA mutation or a similar mutation. And so it can be very specific and quite effective for treating the pancreas cancers. So this is a patient that I had many years ago who was on a trial of a platinum. These are the compounds I told you that actually seem to help chemotherapy-wise for patients who have got BRCA mutations, and combined with PARP inhibition. He had male breast cancer. He had a BRCA2 mutation. And I circle this area here, which shows this hypodensity, this light density, which is where his pancreatic mass was. He had multiple liver metastasis. And he went on to chemotherapy. And then when he could no longer get the chemotherapy combined with the PARP inhibitor alone. And he lived for many years, actually, on this combination, which is not the normal for metastatic pancreas cancer. So recently there's been a paradigm shift. There was a trial that looked at patients who received the platinum compound. It could be any of the ones that we talked about. And then went on to maintenance of laparib. So it turns out there's cross resistance. If you're resistant to platinum, you tend to be resistant to the PARP inhibitors as well. And so these are patients who had germline BRCA2 mutated pancreatic adenocarcinomas. They received platins for at least a few months, and they had a response or stable disease, and they go on to maintenance of laparib. So this is oral, much better tolerated. Our patients love it, and you can see that there's a progression-free survival. There was not an overall survival benefit, but a lot of the patients who were not given a laparib, a PARP inhibitor, went on to receive it. So this data over here for survival is contaminated those that got crossed over or went on to subsequent lines of therapy with it. What about mismatched repair? So this is, if we take a look at DNA, and there's two strands of DNA, this is a mismatch. in duplicating the DNA. Instead of being a guanine here paired to the cytosine, there's a thymine. And in normal DNA repair, you'd repair it correctly. In defective DNA repair, that is, it's mismatched repair defective, you'll see that it actually goes the wrong way. So instead of putting the guanine in there, you put an adenine on the other strand. And how can we find this? Well, it's very interesting. One of the ways that we can find it, there are DNA techniques, but immunohistochemistry works extremely well. These are monoclonal antibodies to one of the four proteins, MLH1, PMS2, MSH2, and MSH6, that code for these mismatch repair protein enzymes. And on the left, you can see there is retainment in the tumor, retaining of the nuclear pattern of expression of PMS2 or MLH1. And you can see here on the left, there's blood vessels and nerves, and they all contain it in their nuclei. And here where there's loss, this is a tumor that's lost MSH2, actually you still see it in the surrounding tissues, but in the cancer it's lost. So it's a very quick diagnostic way of figuring this out. So what does this cause? If you can't repair your DNA, you cause mutations. Sporadic adult tumors have a very low number of new mutations. Mismatch repair tumors have thousands. And so some of these will actually cause there to be a new protein that is coded, or a new peptide that is coded. It's unique, and the immune system can see it. And within the normal immune-mediated presentation, if this peptide, which we call a neoantigen, so it's a new antigen that your immune system gets processed by the antigen-presenting cells, and what happens is there's a breakdown in noticing that that is incorrect. And so one way, on one level, though it's not really the only way, when you use a checkpoint inhibitor, in most of our cases these are PD-1 inhibitors, you resensitize, in a sense, the immune system, the presentation of these antigens to the immune system, and you'll actually be able to have durable responses. So this is a paper from Young Lee at Hopkins, where they looked at all tumors that had mismatch repair, solid tumors, and you can see that a lot of the patients had deep responses. And what's interesting is that you can see once you get past about a year, very few people will actually ever relapse. And so these are people who have 50, 60, 70% chance of a durable overall response. So to give you an example, this is a gentleman of mine with metastatic pancreatic adenocarcinoma. We gave him chemotherapy one for a number of months, but he had toxicity. We had to switch to another one. He had a good response for 9 months, average for that chemotherapy, and he had very rapid liver, lung carcinomatosis. And we started at about this time doing mismatch repair on all cancers, including pancreatic cancers. Found he demonstrated a loss of one of these mismatch repair genes, and started him on pembrolizumab. And he actually went on a trial, and this is his tumor marker, and you can see within weeks normalized, and still alive many, many years later. Where he clearly would never have lived this long if it wasn't for that. What about other directed therapies? So this is a paper Dr. Singhi, who gave the first talk, and I put together about a year ago. And it looked at people who had KRAS mutations, which I told you is the bulk of the pancreatic cancers. They still had some other mutations that we could demonstrate. But what was really amazing in those patients who had a KRAS wild type had something else driving their tumors. So about 10% of these patients had BRAF mutations, epidermal growth factor mutations, HER2/neu, which is very prominent in breast cancer and stomach cancers, FGFR2, recently a translocation in this gene in biliary cancers. There was a targeted therapy that was approved for it. And other rarer, but like RET, ALK, NTRX, these are all actually targetable. And in a prospective study that looked at the germline mutation, these were unselected, newly diagnosed PDAC patients. You can see a number of genes, about 7% of all the patients had underlying hereditary causes. So either you can target this, but if nothing else, you'll be able to discuss with their family what their risk factors are. So to give you an idea, this is a young gentleman who presented with fatigue, diarrhea, and jaundice. Pointing to the arrows here are tumors that he had. This is post his pancreatic resection. And he turned out to have an ALK mutation. There's ALK inhibitors, and he actually had a very long and durable response with an ALK inhibitor. So I'm going to go away from some of the targeted therapies to just a few minutes in pancreatic cancer treatments in general and start off in the metastatic setting. These are patients who have disease outside of their pancreas. Until 1997, not much was known. A compound called gemcitabine was compared to 5-FU in 1997 and showed an improvement in survival. The FDA looked at this, went, but actually the quality of life of people who were on chemotherapy was superior and approved it. And then I like to talk about the 15 years of the desert, because what happened is if gemcitabine was good, gemcitabine and anything, I would like to say everything else must be better, and pretty much nothing actually panned out for this entire time. Until a triplet combination of a drug called 5-fluorouracil, another one irinotecan, and oxaliplatin broke the model of gem plus something else. And so it's harder to take, it's a little bit more toxic, there's more fatigue, but interesting, the quality of life was improved for those who received it. All the drugs are off patent, so further large trials are difficult, but the median overall survival, that means half are living more than a year. Another one, Abraxane gemcitabine, there's no intertrial comparisons to FOLFIRINOX. Multiple patients had poor performance statuses, and there was a 50% disease control rate. You can alter the normal schedule to actually be able to give less intense therapy with good effects. We can sequence this, so we can do first line this, second line parts of that. And so with proper dosing, metastatic patients' median overall survival has doubled from 6 to greater than 12 months, with finally 2 and longer year survival. So, you know, Alex Trebek is now headed towards his second year, and that's becoming less unusual. How about adjuvant? Surgery is the only real cure. You'll hear at the end about surgical options. But one of the things is pancreatic cancer is a systemic disease. So even at the time that it is diagnosed, it has been around for about a decade or more, and it learned to become metastatic many years prior to when we would remove it. So what happens is we would see a cancer, say it's surgically resectable, and actually very few months later, they present with metastatic disease. It never recurred. It just was always there, but micrometastatic. So the idea is to give adjuvant therapy. I'm going to give you a decade in just one slide. Gemcitabine alone doubled the overall survival at 5 years. If you added 2 drugs, gemcitabine and an oral 5-FU capecitabine, it improved the survival by 75% alone. Median overall survival from 16 to 28%. And it turned out if you give FOLFIRINOX, it's now the standard of care. The median overall survival is about 45% in 5 years, so much higher. Radiation, I'm not going to really talk about because it's yet undefined. How about some patients have cancers here in the head that are near blood vessels, be they the celiac or the superior mesenteric arteries, and they can't be removed. And some of these make it difficult, borderline or locally advanced. And so for these people, what we can do is offer chemotherapy and or radiation prior to surgery to try to make them removable. So talking about prior to surgery therapy, the potential benefits is occult micrometastatic disease can become visible, so you save them the resection morbidity. Whipples are not as bad as they used to be. Don't be scared of them. Potential to decrease rate of positive margins, deliver chemotherapy without delay. And what's interesting is about 1/3 of patients either don't get adjuvant postoperative chemotherapy, which we just said improved survival because they didn't recover well enough. So giving them something ahead of time is better than giving them nothing. So whether this approach is better in resectable disease, it is the standard of care in borderline and locally advanced disease, and though we do it a lot in resectable tumors for these potential benefits, it should be limited to trials whenever possible. So in summary, it's been a difficult disease to treat. We find these relatively late in the molecular progression, relatively treatment resistant, showed you they have complicated genomics. There's a fatalism. There was a study done at the VA system that up to half of patients who saw their PCP with pancreatic cancer were told not to go on to any sort of treatment. Surgery has improved. There's been significant strides in the past 2 and 3 years in all sorts of treatment. And multidisciplinary care has become the norm. Medical oncology, surgical oncology, pathology, GI, helping us with biopsies and ERCPs and drainage, radiation oncology, nutrition, palliative care, social work. All of these I'm studying because we actually have a clinic that meets with all these people every single week to try to give the patients an all-inclusive help. So with that, we'll hold questions until after the next talk. Here's a nice picture of downtown Pittsburgh for those of you who are missing it because we're not at PancFest.
Thank you, Nathan. Wonderful high-level summary of pancreas cancer. And please